complain.
As I always say, it's better to be busy than bored, because when you're
It
bored,
is.
right, you're wondering what's happening in life.
Yeah, absolutely.
Right, I think we've waited a bit of time, so what we would do is we'll crack on. All right.
Yep.
So welcome to today's Nexus Fertility webinar, from lab coat to life, the embryologist role explained. We're very lucky to have Lyndon Miles here today with us, and he is a consultant embryologist. And we will get into conversation with you very shortly, Lyndon. Just before I do that, I just want to read the disclaimer. And that is that Nexus events are designed to provide objective insight and balanced information and general guidance. They are not designed to replace professional. Oh, that was my Alexa turning on. Alexa, stop. Never had that happen before. Right, where were we? Let's start from the top. All right. Disclaimer. Nexus events are designed to provide objective oversight, balanced information, and general guidance. Nothing shared during these sessions is intended to replace professional medical advice. Always consult your professional healthcare provider with any questions, concerns about your health, fertility treatment, and changes in your condition. Sorry about Alexa. Sometimes she butts in. So let's start from the top. Lyndon, can you give us a bit about your background and how you've come to where you are today?
Yeah, as brief as I can. I've been an embryologist for just over 32 years. Some of that in the UK, some of it in the US. And I've worked at various clinics. And then back in about 2006, when I returned from the US, I opened my own clinics. So I had 5 clinics in. And now I'm currently, my clinics have recently been taken by Care Fertility, and I work with Care. So heading into year 33 of doing IVF, and I'm still working with egg, sperm, and embryos all day, doing everything up to and including genetic diagnosis of embryos.
Oh, that's amazing. 33 years. That's you're the perfect guy to have on to answer every question I've got for today. Then lots of experience. So obviously, this is for anyone who's listening now, live, or in the future. Listen back to it, to give them a bit of an understanding of what happens when that semen analysis goes behind the door, the dreaded door, as we were talking before we came live about my own personal feelings towards it when I was having my own personal journey. So after the sample is given, and you take it to that hatch in the door and it goes behind the door, what's the initial first thing that happens to that sample?
Strangely, the first thing that we do actually with it is actually nothing. And one of the reasons for that is that when a sperm sample has just been produced, it's very viscous, it's very, very thick. So it's actually difficult for us to handle it. And for us to be able to count it accurately, it needs to liquefy. So we're probably going to leave it for probably 10 to 20 minutes typically, during which time the sample will go from being thick and viscous to being almost watery in consistency. And then once it gets to that point, we can then assess it. Just to backtrack a little bit on that point, we often ask patients to abstain from sexual activity, typically for between 2 and 7 days. Some clinics you'll hear say 3 to 5 days, which is right between that 2 to 7. And that bit's fairly key, because if a patient abstains for less than 2 days, the sperm count will often appear artificially low. And if they abstain for over 7 days, the percentage swimming, the motility, will appear low. So once the sample is liquefied in the lab, so sometimes after 10 minutes, you can literally tell by picking up the pot and just swirling it a little bit as to whether the sample is liquefied. And once the sample is liquefied, we'll then take a pipette just to give it a mix, check the volume, see how much volume there is, because that's one of the parameters we check. And one of the reasons we like to give it a good mix is because we're going to take a tiny drop of it to do a sperm test on it, a semen analysis, and we have to make sure that that little drop is reflective of the whole sample. So we give it a mix. We take a tiny droplet, which is it's called 5 microliters. It's probably smaller than a teardrop, and that goes onto a special chamber, or indeed sometimes into an automated computer, and we do the count that way.
Yeah, it's interesting. It's I'm thankful that you went back to talk about, you know, the before you give the sample, because that was quite a big thing. I remember not knowing how long to kind of sustain for and having those questions of what it would do. So it's definitely useful having that bit of information. But that should come with your clinic should provide you with all that information as well. Is that correct?
Yeah, they should. They should give you that as you book in for a sperm test. But I do find that guys get really obsess over it. And really, as long as you're between that no less than 48 hours, no more than 7 days, you should be fine.
Oh, that's good. That's good to know. Because like you said, yeah, you can become, I remember becoming quite fixed on it, really being worried in terms of not knowing if you know, if 4 days was too long or if 2 days was too short.
Yes.
Yep. And I guess it's just another layer of the anxiety linked to this kind of treatment, isn't it? You know, another thing that you're trying to control, but you don't quite know how to control it.
Yeah.
But no, it's good to hear that. Thank you. So now that they're doing the analysis, is there anything different in terms of how they analyze it for an IVF cycle compared to an ICSI cycle? Because obviously, or is it the same?
I mean, very often the first time we see a sperm sample for a patient, it's very often a diagnostic sample. So if it's a diagnostic sample, that'll be the first time we'll get an indication of what treatment a patient's going. The one thing I would say of that is we shouldn't always read too much into looking at a single sample. Whenever we see a sperm sample, that's something that the body's made probably around about 3 months before. So if, for instance, 3 months before the patient had got a fever or was taking medication or was particularly unwell, then 12 weeks later, we will see that in a sperm sample. So sometimes we will get a guy who will produce a sample and maybe parameters will be poor, or sometimes there are no sperm present. And we'll say to them, well, that's just reflecting 3 months ago. And if we now wait for a few, we can look at a sample to see whether that's consistent or not. But getting back to the question, so I guess the key thing would be we look for what we call normal sperm parameters, which are parameters set by the World Health Organization. And effectively, if the patient's sperm count is right, there's several values: the volume, the motility, the count, the speed it swims forward, the shape of the sperm. We look at all of these different things. If it's within normal range, then they're very often going to be for IVF. If any of the parameters are suboptimal, so we have a lower count or a lower percentage of the sample swimming, or they don't swim so well in a straight line, or we have a tiny volume or something like that, then they're more likely to need ICSI. The way we deal with the samples, the way we sort of prepare them from that point, is basically the same. So whether we're doing IVF or ICSI, we prepare the sperm samples in very similar ways. But it just depends what we're going to do with that sperm at the end, whether we're just going to take eggs and sperm and put them together with IVF, or whether we're going to inject sperm into eggs with ICSI. And the last thing I would say about that is sometimes it can even change on the day of treatment itself. So even if a couple have come in, they've had a sperm test done, everything is completely normal, and they're going to come through for IVF, and 8 weeks later or 12 weeks later, they come in for IVF, and on the day of egg collection, he produces a sperm sample, and his sperm parameters are poor on the day. And that occasionally happens because sperm parameters fluctuate. It's sort of normal for that to happen. So sometimes, even if a patient's set up for IVF on the day of treatment, we can switch and do ICSI, which is there's very little difference in how we prepare the sperm sample.
Yeah, I think that's a really good thing to mention as well about the fluctuation. A lot of people don't realise that it's quite natural to see a fluctuation in your sperm maybe quality because of things that have happened in your life, like you've just said about if you've been ill.
Yeah.
if you have been ill, is it like, do you have to wait those 3 months to see it affect, or would it be like if you went the next week and gave a sample, would there be
Yeah, that's a great question, and as I often say to the patient, so if a patient does come in and they produce a sperm sample for a diagnosis, and the sample is the parameters are lower than we would expect, I'll always say to them to wait about 4 weeks to do another sample, to do a repeat test, because that way we've moved 4 weeks further on. So if there was any effect from 3 months ago, that would be changed if we wait another 4 weeks. I would say the same things about medication. So sometimes patients something which can have an effect on sperm production. And if they're taking medication that has effect on sperm production, it's going to take maybe 3 months for those effects to disappear. So depending on if they're taking medication or if they did have a fever, I mean, especially when COVID was around and people were getting temperatures and things, and we would see sperm counts come back low. And then sometimes we'll say, and very often I'll say to a patient, wait 4 weeks, do a repeat test. And when they do the repeat test, everything's normal. Not always, but it just shows that fluctuation just happens. Even when patients, their health hasn't changed or they've not been taking medication, some patients will produce a sperm sample, it'll have 20 million, and then 4 weeks later it'll have 35 million for no other reason than counts can go up and down, as can motility.
Yeah, yeah. I think it's just really useful information for people that are listening to this to have that fluctuation. Is there anything, obviously, that there's in terms of illness? It could be like 3 to 4 months, and then you've mentioned medication. Is there anything like outside of that, apart from obviously clear things like cancer treatments, that could affect it longer term but come back around, if that makes sense? Or is it just individual?
Not really. I mean, the only one that I would come back to is smoking. That's the only one that has a fairly consistent problem with sperm samples. And not only that, but also if you then create embryos in IVF or ICSI with a smoker, it does have some effect on the way the embryos develop.
Right.
So, that would be an ideal for. And I don't smoke, so I'd have no idea of how difficult it would be to stop smoking, and I'd imagine it's very difficult. But that's a major factor to improve chances, is to stop smoking.
Yeah, that's well, there's not really I always view it, there's not really any positives apart from the feeling you get maybe when you do smoke. There's not many positives to
Yes.
smoking. It's one of the worst things you can do for your health, but it can be incredibly difficult to kind of tackle that, I can imagine. Which, if anyone was listening to this and struggling, contact your doctors. There's plenty of strategies and support out there to kind of help you stop.
One of the things, just to quickly add to that point, the only other thing that I'm seeing over the years more and more is guys who are, for sporting reasons or bodybuilding. I see quite a lot of guys who are using anabolic steroids
Yeah,
or pro hormone, things like that.
yeah,
And I don't think many guys realise the often irreversible effects of doing that. So guys who use things like anabolics and steroids, very often, sometimes I see those guys when they've stopped producing sperm,
right.
and if they've been on those drugs for some period of time, there are cases where the sperm production just won't come back.
Yeah, it's I think we've talked about it on the podcast about how there's quite a culture of it now.
Yes.
People feel like they have to be at a certain level in performance, or
Yep.
aesthetically they want to look a certain way. But that does come with clear, often not clear, but with consequences.
Yeah.
So yeah, if anyone's listening to this and taking anything they shouldn't, in terms of steroid wise, it's definitely worth getting checked out and and coming off, because if the earlier you come off it, if it's going to come back,
Yeah.
it will, and then you
Yeah.
can kind of obviously talk to your clinic and your consultants about maybe a treatment plan, or what the future might look after coming off of it.
Yeah.
Because I think it's a secret or a silent kind of assassin for sperm sometimes, and people don't
Yes.
realize how bad it
Yeah.
is for you.
Yeah.
Well, we've talked briefly, talked about the parameters. So what
Yep.
are those parameters that you're looking for when you're analysing that sample?
Yeah, so we're looking for about every 10 years or so, the World Health Organization do studies on male fertility around the world. And this basically involves lots of studies being done in countries all around the world and what the reference values are. And every 10 years or so, these can change a little bit just based on male fertility around the world. So for instance, we look for several things right now. So we will look for the volume of a sample, and the volume of the sample should be 1.5 milliliters or more. So generally, we'll see a lot of samples in that sort of two to 3 milliliter volume. So if it's less than 1.5, then that tells us that the one of the parameters is already suboptimal. We then move on to look at the counts, which is, I think, the one thing that people probably obsess most over. They think it's the most important parameter, but they're all as important as each other. So the sperm count should be 15 million, so 15 million per milliliter or above. And we then look at the percentage of the sample that's swimming. So what percentage is motile, is moving along. And at least 40% of the sample should be swimming. And of that 40%, 32% of it should be swimming very well. So we split the sperm up into ones that swim well and ones that just sort of move on the spot. And then lastly, we look at the morphology, so the shape of the head, the neck, the tail, which is the one I personally think is the most contentious one, and which is one of the parameters that I think, again, that patients really obsess over, and often unnecessarily so. But the thing that's important with all these parameters is they're all sort of dependent on each other. So, if a guy has got a sperm count of 25 million sperm, then that's greater than 15 million motile, which is what we're looking for. So that means he's within normal parameters. But if only 10% of that sample is swimming, then that means that a relatively small number of sperm are swimming along. So just to have a normal sperm count isn't the be all and end all unless you also have normal motility. And likewise, if a guy's got a sperm count of 100 million, which is a very high count, but the volume of the sample is tiny, it's only zero 0.1 of a milliliter, then he's not going to have 100 million sperm. He's going to have less than 100,000. So we have to look at all of the parameters. Not one of them is any more important than the rest, and they all sort of come hand in hand. And we have to look at each one of those parameters and see whether they meet World Health Organization standards as what constitutes normal fertility.
Yeah, I remember being quite caught up with my sperm count in terms of how many are there. And it wasn't until you kind of get down the road into your treatment a bit, you realize how important the rest of it is. You can't have one without the other, and you kind of want that balance through the whole sample. So in relation to different labs, do they have different parameters? Because I remember in terms of levels, because I remember going to one lab and being higher than I expected, and then being somewhere else and it being lower, in terms of they kind of were reading them differently. Maybe
I mean, you'll get a little bit of difference in results when, so like I said, about every 10 years the World Health Organization update the parameters, and what you tend to find is that when World Health Organization update, you'll get some labs that will, for a year or so, stay with the older reference values. So that can account for a little bit of difference. But I think probably more what you're asking is, how can there be a difference? If you took your sample and split it in two and gave it to two labs, how could you get different results?
Yeah.
And really, the things like your sperm count shouldn't really differ between two labs. It should be similar. So should your motility, so should the speed of the sperm. The one that's the contentious one, which I alluded to a few moments ago, is the sperm shape, the sperm morphology. I've always felt, as do a lot of my professional colleagues, that sperm morphology is a very inexact science. In my career, the reference values for what is normal has changed a lot, and now anything over 4% normal is considered normal. So what I mean by that, if we look at 100 sperm and 5 of them are normal, then that sample is considered to be normal. But sperm, it's a bit like beauty's in the eye of the beholder. And you could give two samples to people. You know, I've done this for 30 years. Give it to somebody else who's done this for 30 years. And on morphology, you may get different results. And that's why the shape of the sperm, the morphology, one of the things I most often get contacted about is a patient who will say to me, I've been told I've got 1% normal sperm, and, you know, they're panicking, what do I do? And it's so rare. You know, I could see 1,000, 2,000 samples a year, and it's so incredible to see a sample that's truly 1% normal and all of the rest are abnormal. And I tend to find that when patients panic and I say, let me see the sample come in, let me take a look. And it's just because I find that with morphology, some labs just really overanalyze, and I don't think they give out meaningful information.
Yeah, it was definitely something that I asked in terms. I didn't ask the clinic because at the moment I wasn't confident enough to do so. But I wondered why one was different to the other. So it's definitely a justified question, and thank you very much for the answer. So if we've analysed the semen, so let's look about how does the sperm meet the egg in relation to IVF? Because there's IVF, and generally when you're talking about fertility treatment, people call it IVF, but there is IVF and there's ICSI. You know, they are two different things. So let's look at IVF to begin with. How does the sperm meet the egg?
So basically the process is that, just to backtrack, when the sperm samples come through the hatch and we've left it there for 20 minutes or so to liquefy, and then we've done the sperm count where we've looked at the parameters, the motility, the count, the progression, all of those things. The next thing we do is we prepare the sperm. And what that means is that we will take the sperm and remove any of the sperm that are not moving, the ones that don't swim so well, the ones that are slightly more irregular in shape. And we do this by a process called gradient centrifugation, which basically, in layman's terms, is we'll take the sperm sample, the semen sample, and it gets layered on top of two little solutions. One is more dense than the other. And these two solutions are made up of millions of microscopic little beads. And when we put the sperm on the top, and then we put it into a centrifuge and we spin it at an incredibly high speed, and the best sperm will get pulled down between those beads, and the ones that are not so good will get trapped in the beads. So after you've centrifuged it, all the best sperm will be in a little pellet at the bottom of the tube, and you take those out. So we've then got the best sperm, and we then wash it, which is akin to giving it sperm food. It gives it things that it really likes to be around. And then a couple of hours later, we put eggs and sperm together. So in the example of IVF, we will take a certain number of sperm, and usually that's around 200 or 300,000 sperm, and we add those to the eggs in a dish. Now, why that number, 2 to 300,000? If we add a lot less than that, then the likelihood of a sperm bumping into an egg and fertilizing it is reduced. And if we were to add in 1 million sperm, then the reverse is true. Instead of one sperm going up to the egg and fertilizing it, two sperm could fertilize that egg at the same time. And if an egg fertilizes with two sperm, then it's irregular and it won't implant. So you have to find that sweet spot where you get normal fertilization. So we would take those 200,000 or 300,000 sperm, add them to the eggs, and then effectively with IVF, we then hand over to Mother Nature. And the sperm are going to swim up to those eggs. In 95% of cases, or 95% plus of cases, they will bind to the eggs. The sperm will burrow through the egg. And once the first sperm is bound, it should lock the egg down to prevent further sperm getting in. And then next morning, we just check with the IVF eggs. We'll take a look at them. We'll be able to see how much sperm are bound to the outside of the eggs. And moreover, by looking at the egg, we can then tell whether the egg is normally fertilized or not.
Yeah, it's an incredible process. Like I didn't know about the little beads and things like that. Absolutely fascinating, and something that I've said it already once. It's not until you actually start looking into it and talking to people like yourself, you find just how much work and processing goes into each stage.
Yeah.
I remember the first time I heard the term washing washing the semen or sperm, I was like, how do you do that? I generally thought, how do you do it? You don't put it under a tap.
Yeah.
But yeah, I guess it's nice to hear it in a different way in terms of actually you put it in something that it actually is like almost feeding it and cleansing it and cleaning it that way.
Yeah.
Absolutely amazing, absolutely amazing. And then, yeah, that IVF is you kind of put it in and let the sperm or let nature do its thing. And then, so what about the ICSI side of things? Because that's what I had. And it was, I thought ICSI was IVF when we were going through it. It wasn't until afterwards I learned that IVF was a completely different thing.
Yeah. So whereas with IVF, we've basically put 200,000 or 300,000 sperm in with the eggs and we let Mother Nature do her thing. With ICSI, the embryologist is a little bit more involved. So rather than putting 200,000 or 300,000 sperm in, we're physically taking a single sperm and injecting it directly into the egg. Now, why do we do that? Because ICSI can get around a lot of the barriers of when there's a problem with a sperm sample. So if a patient has a lower sperm count, and by looking at that low sperm count, we think that if we do IVF, there's a chance they won't get fertilization. We can pick up individual sperm and inject them into eggs. Likewise, if a patient has 90 million sperm, but only 5% of them are swimming, same problem. If you do IVF, you're probably not going to get fertilization. If you've got a sample that's got millions of sperm, but they all swim incredibly slowly, then again, if we do IVF, there's a chance that fertilization may not happen. So whenever we see a problem like that, the one way of getting around those problems is to do ICSI. So the sperm sample has been prepared much in the same way that we did with IVF. So it still gets centrifuged, it still has to go through the beads, we still catch the best sperm. What we then do with that sperm is we'll take a tiny microscopic little drop of it, and it gets put into this tiny little microscopic lake of something called PVP. And PVP is about as treacly a solution as you could possibly get. And the reason that this solution is so thick and so treacle-like is because I have to catch sperm individually with a tiny little needle. And if those sperm were swimming around in something that had the consistency of water, they would be flying along and I would have no chance of catching them. So I have to put them in this little lake of PVP, which is super viscous. And what that does is it makes it incredibly hard for them to swim. So it slows them down a heck of a lot. And once you leave them in that little viscous drop of solution, after a few minutes, the best ones will make it to the edge of the lake. So I just go to the edge of that microscopic little lake. There will be sperm that have made it there. And then I will find a sperm that has normal head, normal neck, normal tail. And just before injecting it into the egg, I have to break the tail. When I say break it, it doesn't cut the tail off. I always say to patients it's akin to breaking its leg. So, if sperm's got one leg and I just break its leg so it stops swimming, I'll then pick the sperm up in a needle. I'll inject it through to the center of the egg, take the needle out, and then I hand over to Mother Nature. So the only real difference between IVF and ICSI is in that moment. With IVF, 200 to 300,000 sperm, let Mother Nature do her thing. With ICSI, a single sperm into each egg, and then let Mother Nature do her thing.
Yeah, once again, a fascinating process, really is. I think to myself, how small is that needle?
Yeah.
Incredibly. I mean, this is real delicate work, isn't it? I mean, you don't get there's nothing smaller than a sperm cell, really, and it's
correct.
incredible work that you guys do. So we've kind of talked about the differences, but what can affect fertilization success? Is there anything that really stands out that you kind of have to be careful of in the lab or be aware of?
Well, normally when we do a diagnosis, when we've looked at a sperm sample, and if it's normal, then, like I said, we will tend to do IVF. And I think I said earlier that in over 95% of cases, if sperm looks normal and the eggs are fine, you put them together, in over 95% of cases, fertilization will happen. That, though, means that, of course, then in less than 5% of cases, fertilization doesn't happen. Now, sometimes when that happens, that's for reasons that we don't know. And actually, it may be that on occasion you'll get a couple come in who've been trying for a baby, it hasn't worked. They've had lots of tests and everything has come back and it's normal. Sperm looks normal, eggs look normal, and then we put them together. And then when we put them together, next day we come in, we find that they've fallen into that unfortunate group of less than 5% of patients where fertilization hasn't happened. And sometimes when that happens, we've actually just probably found out the reason they weren't getting pregnant, because the eggs and sperm meet, but then the lock and key doesn't quite work right. And what we didn't know with that couple is that with the benefits of time travel, if we'd have done ICSI on them, they would have probably been fine and have got normal fertilization. So sometimes patients will therefore say, well, why don't we just ICSI everybody and not do IVF at all and get rid of that 5% risk? And that's because the main reason is we're trying to do things as naturally as possible. I don't really want to stick a needle into an egg when I don't have to do so. But I think one of the considerations for patients, especially those who are going through for treatment and have never had a pregnancy, they've never had IVF where fertilization's been proven, one consideration they could do is to hedge their bets. And let's say they get 10 eggs. Then if the sperm is sufficient, why not do 5 eggs with IVF and 5 eggs with ICSI? And if you were unfortunate enough, therefore, that the 5 eggs you do IVF on fall into that group where 5% chance they don't fertilize, your ICSI ones kind of act as a bit of an insurance. So that's the one way to go. The only other thing that could really influence fertilization would be incredibly poor sperm samples. So if we're doing ICSI, which tends to be for male factor fertility, sometimes you can get samples where it could take us an hour to find the 7 or 8 sperm with which we want to inject and fertilize the eggs with. Now, as long as in that hour or 2 hours of searching, we find sufficient sperm that are of normal shape and that are moving, then we can fertilize those eggs and they should develop normally. But if you do get a patient, one of those very rare patients where all of their sperm are abnormal in shape, and you do ICSI on those, then those patients do tend to do poorer in terms of both fertilization and how the embryos develop. So the parameters would be important in that regard.
Yeah, it's sometimes I think it's, especially for the guys, it's difficult to fully accept or kind of process the amount of work that goes into what you guys are doing, and the awareness of during this process that you're on it. And I remember feeling very stressed and worried that it was just all going to go wrong. What you've explained there, like, guys listening to this should know that obviously things do come up. There are common issues, but you guys know fully what's going on and can not control it to a certain extent, but you play your role and effective in what you guys do. I remember being very, very anxious about it. That fertilization stage was really difficult for me. That waiting game probably was the worst bit.
And it's funny because you don't tend to hear or see the anxiety from the men so much.
No.
You tend to see the guys tend to sit quietly and not say too much.
Yeah. I think it's a bit like a protection mechanism for ourselves. If we open up, it means we open up emotionally, and that's a different conversation of why we don't open up emotionally.
Yes.
But yeah, it was an incredibly anxious time for me. And I was, the question is, have I done something that will affect that fertilization? That came up in my head, and things like when we weren't successful. But like I've said previously, like I know a lot more now, and you guys are on it and know what you're doing. Which isn't, we cannot underestimate how important your work is, and it's tremendous. So, but let's have a look at in terms of if someone's has azoospermia and they have a Micro TESE, because we have several guys on the Nexus support group and also in terms of the community that have had a Micro TESE. What role does an embryologist play in that? Because
Okay, well, just to backtrack a little bit on that. So, firstly, um, to just talk a little bit about azoospermia. So, azoospermia is when we don't see any sperm present. So, I would say perhaps 2 to 3% of the patients I see will come in and produce a sperm sample, and there will be no sperm in the sample, no sperm in the ejaculate. As I said earlier, when I see that for the first time, nothing to panic too much about. Although obviously the guys will panic, and very often then I will say to them, okay, could be 3 months ago you had a fever, it could have knocked your sperm out, all of these type of things. Let's wait 4 weeks, let's retest. 4 weeks later, they come in, retest. Some of them will have sperm, some will have normal parameters. Of course, some of them will still have no sperm. If then we've done 2 tests a month apart and there's no sperm, then that's suggesting that there's a more consistent issue. Now, I'm assuming, for instance, that this guy who's produced no sperm isn't somebody who's had children previously. So if they've had children previously, then we know that at some point they've produced sperm, unless, of course, they've had a vasectomy, which has blocked that sperm sample from leaving the body. So then we have to figure out whether the patient is what we call obstructive or non-obstructive azoospermia. So as the name suggests, obstructive azoospermia is where there's a blockage. So sperm's being produced, but it just can't get out of the body. And for instance, there are some guys that are born without a tube called a vas deferens, which is a tube that carries sperm. So they're making sperm, but the sperm can't get out of the body. So they could have obstructive azoospermia, just in the same way if a guy's had a vasectomy, so he had a family, and then suddenly he's met a new partner, he wants to have children again. Even he's considered obstructive azoospermia. He's had a vasectomy, he still produces sperm, but he doesn't come out of the body. And then there's non-obstructive azoospermia, which is where there's no sperm being produced, but there isn't a blockage. So if somebody comes in and they're not producing sperm, we've done a couple of tests. One of the first things we do is then get them to check some hormones. So hormones, things like FSH, LH, testosterone, prolactin. So they're probably the 4 main hormones. And by checking those, we can then tell whether a patient has obstructive or non-obstructive azoospermia. And whichever one of those they have will give us an indication of what is the likelihood of us getting sperm if we do a surgical sperm retrieval. So you just mentioned Micro TESE, which is one of the several ways in which we can surgically remove sperm. So for a surgical sperm retrieval, so people may have heard of names like PISA or TESA or TZ, and these are all subtle variations on the same thing, which is surgical sperm retrieval. So the first step in that would be we will try to take sperm from a structure called the epididymis. And the epididymis is basically a little reservoir on the side of the testicle, where so the testicle has produced sperm. The sperm, when they're matured, will sit in this little reservoir, and that's where they will leave from at ejaculation. So we could have a guy come in for a procedure where we'll give him sedation or a local anaesthetic, so can't feel anything. And then we'll pass a very fine needle into the epididymis and just draw back the syringe, and we'll take aspirates from the epididymis. And in some cases, we will find sperm just by doing that, and we can freeze them. And then those sperm, some months later, we can use them for ICSI, which we've already discussed, where we inject sperm into eggs. Likewise, sometimes we will go into that little reservoir, the epididymis, and we don't find sperm, which means we then take the next step, which is where we take what we call seminiferous tubules. So a small incision where we open the testicle, and inside the testicle we can see these little tubules, which under the microscope look like boiled spaghetti, tiny little spaghetti-like structures. And we can take those, and under our microscope we can empty the contents of those tiny little tubes, and sometimes we can find sperm that way. And if we find sperm, again, we can freeze it, we can use it for ICSI some months later. So the main role of from the embryologist's point of view is we're the person taking either the fluid or the pieces of testicular tissue, and then we're searching for the sperm, and any sperm that we find we're then freezing for future use.
And then do you analyse the sperm the same way as you would a sample that's been given?
Yeah, to some extent, the only difference is that with an ejaculate, even in guys who need ICSI and produce sperm in their normal ejaculate, very often you're seeing sperm counts that are could be 1 million, 2 million. So very often they're in the millions. Whereas when you're finding sperm from the epididymis or from the testicular tissue, these can be sperm that are sometimes not even in the hundreds. Sometimes they might even not have made it barely into double figures. So, you might be seeing 20 or 30 sperm or, 2,000 sperm. And 2,000 sperm might sound like a heck of a lot, but in fertility, that's an incredibly small number that you could only do ICSI with. But apart from that, you still look at, if you can do a count, you will still look at the shape of them and if any of them are swimming. But you're dealing with much, much smaller numbers.
Yeah, yeah, it's interesting. It really is, because obviously it is a very invasive kind of surgery. It still
Yeah,
makes my eyes water a little bit when we talk about it. Like, you can't. I
mine
think,
too.
as a man, it's quite
Yeah.
not the most pleasant of thought, but it is such. I mean, it's an amazing thing. Like, I'm not sure how long have these kind of surgeries been. Have we been doing them for?
Oh, well, I mean, I've certainly done it my whole career, so um, certainly over 30 years.
Yeah,
I would imagine, I mean, ICSI was pioneered back in 1993,
yeah,
and before 1993, any guy who had got a sperm parameter problem didn't have many options
mm,
apart from maybe using donor sperm. So I would imagine the first surgical sperm retrievals would have been done probably in the mid 90s, sort of 95, that type of area, I would imagine.
yeah, yeah. I always think to myself, especially like with surgeries like this, like someone had to be the first, and it's definitely a
Yes.
brave guy that went first.
Yes. Yeah, for
and,
sure.
and if it wasn't for those guys that said yes, let's give it a go, there'd be there'd be children today that aren't here. So they did a fantastic, brave job in terms of saying, yeah, let's try it. Um,
And it's
right.
so,
So,
it's so common. I mean, the other thing I was going to say, we were talking about IVF and ICSI. The one thing I sort of didn't mention was the sort of split between the two. And in most clinics, you tend to find that it's more or less 55% is ICSI and 45% is IVF.
mm,
So sometimes when I tell a guy that we need to do ICSI because of a low sperm count or low motility or something, I think they think that they're an incredibly rare patient, when in
mm.
fact the greatest proportion of our patients fall into that group.
Right. Okay. That's I didn't know that. I didn't know that it was a larger population. Has that changed over time? Because it's
I don't think so. I think the only thing that's changed is embryologists have become maybe a little overcautious. We're very wary of all of your hopes and wishes
mm,
are in a dish or a tube in our hand. And likewise, very often, especially for patients who are paying privately, that's not an inconsiderable sum of money, and we're very conscious of that. So, if we get the slightest concern when we look at a sample, if even the smallest alarm bells start going off, we'll go and speak to the couple and say, "There's something I'm not quite happy about, and I'd be safer if we did ICSI."
mm.
And I think because of that, it's become a little bit of a crutch for embryologists whenever we get a little bit nervous. I guess it's like VAR in football.
It's
Um,
there, so
and
use it.
yes, yes. So I think maybe we could be guilty of perhaps using ICSI a little bit too much, and maybe over the years that's probably happened.
I understand that though, because of what you've explained is exactly what, as a patient, I would be like, well, I'd rather go with the
Yes,
safer option.
yes,
One because of the financial investment, but the emotional one.
yes, yes,
Everything is pinned on that treatment, and if it's another thing you can kind of get rid of, or in terms of, well, we can kind of take that little bit of risk out of it, we can do this instead, which will kind of get over that, or this is our concern. So we
yeah,
think you just go with what you've told, and yeah, I completely
yeah.
understand that from an embryologist's point of view. One thing I remember distinctly kind of pondering about was embryo grading. All right.
Yeah.
What does it mean, and how important is it?
It is pretty important because there's a very strong correlation between how an embryo looks and how it's developed
Mm.
and its likelihood of implanting. I mean, there are other factors, female age and the lining of the uterus and all of these things, but the embryo quality is very important. Now, the vast majority of patients who listen to this video, if they're having treatment or they've had treatment, will have had embryos transferred in the greatest likelihood on day 5 of development. Day 5 of development, as we call it, the blastocyst stage. Historically, and certainly back when I started my career 3 decades ago, we did not do day 5 transfer. The technology wasn't there to grow a human embryo to day 5 to the blastocyst stage. And we used to put embryos back when they were 2 days or 3 days old, which is either at the 4-cell stage or the 8-cell stage. And that's something that we call the cleavage stage. But I would say that, I don't know, 99% of patients, or certainly of my patients, have a day 5 transfer. And one of the reasons for that is by growing an embryo to day 5, now that technology allows us to do that, you get to weed out the embryos that are less likely to make it. Sometimes I draw an analogy with patients that when embryos grow, it's a bit like watching a marathon race. And if you put an embryo back when it's 3 days old, when it has 8 cells, that's a little bit like being stood at the 20-mile mark of a marathon. So you've got an idea who's going to win, but it's fairly vague because there's going to be a lot there.
Yeah.
Whereas if you do a day 5 transfer, that's the 25-mile mark. So less of them are going to make it there. But the ones that make it there have got a much higher chance of winning or with an embryo implanting. So the way we grade the embryos on day 3, which very few patients would have now, we would look at the cell number. So a day 3 embryo should have roughly 8 cells. The 8 cells of that embryo should be symmetric. So we're looking at the symmetry of the cells. And also little bits of the cells break away, what we call fragments. So we're looking for those things. And for instance, in terms of symmetry, an embryo, when it's at the 2-cell stage, should have 2 symmetric cells. And when it's at the 4-cell stage, should have 4 symmetric cells. But if an embryo is between there, 3, 4, or 5-cell, by definition, the embryo cells should be asymmetric. Likewise, if I look at an embryo on day 3, it should have 8 cells. But if I look at it when it has 9 or 10 cells, they should be asymmetric. So depending on how many cells it has dictates whether the cells should be the same size or not. What's a lot more common and what a lot more patients will see will be a day 5 transfer. And a day 5 embryo is much different to a day 3. So we can no longer count the cells anymore. Whereas a day 3 embryo had around about 8 cells, a day 5 embryo may have 120 to 150 cells. So it's implausible to try to count them. But also, not only can we not count them, but the cells of what we call differentiated. So whereas the day 3 embryo, which had 8 cells, and those 8 cells could go on to become anything, placenta, fetus, skin, bone, nerve, anything at all. By the time the embryo is at 5 days, so 2 days later, the embryo cells have already split. So some of them are placenta, some of them are fetus. And the way I best describe it to a patient is that a day 5 embryo is very much like a football. It inflates like a balloon. And when it gets to a certain point of inflation, we're looking at the outside of it, and the outside of it is the placenta. And that should look like the surface of a pineapple or a patchwork quilt. So it should have those 100 little patches all the way across it, just like the surface of a pineapple. What we don't want to see is an embryo that has the surface like an orange skin. And I actually use these fruit analogies a lot with my patients. So if it's like the surface of an orange skin where it's just one continuous layer, that's not what we want to see. That doesn't make it easy for the embryo to implant. If it looks like the surface of a pineapple, then that's perfect. That means it has a good chance of implanting. And then you can get somewhere in between. So we grade embryos A, B, and C, and an A would look like the surface of a pineapple, a C would look like the surface of an orange, and a B would look somewhere in between. And for sure, an embryo that's an A or B would have a better chance of implanting than one that's a C. Likewise, when that embryo has inflated it like a balloon, and we can see that surface, the placenta that looks like a pineapple, right in the middle of that inflated balloon will be a little structure that looks like a clenched fist. It looks exactly like that. And that's the fetus itself. And we can see the fetus sat in the middle of the embryo. And we score that A, B, and C as well. So if it looks like a fist, it's an A. If I can't see it at all, it's a C. And if it's somewhere in between, if it's a loose fist, it's a B. So we grade the embryos on day 5 on those 3 things: how inflated it is, and once it gets to a point of inflation, we look for the fetus and the placenta. And if an embryo has a really good grade, then there's a good chance of it implanting. If an embryo has a lower grade, then the chance of it implanting is lower, though, like I said, other factors come into play.
Yeah, it's incredible how fast it grows. Just in a matter of days. It was something that really it was one of those surprises that you never expect. I've forgotten what it was called, but we were able to watch the development.
Yeah, and actually, I mean, I don't know whether I can share my screen, but I kept a video at hand here if you wanted me to put one up and show you.
Yeah, you should be able to share it.
I'll have a quick go. I don't know if it'll work. But,
that's all right.
Let's see what
that middle bit there says share screen. So if you click that, you should be able to share your screen.
Yeah,
it's absolutely incredible to watch. And the fact that it happens in days. Here we go.
I don't know. Can you see my screen now?
Yeah, I can. Yeah.
Yep.
Yeah.
So this is and so if I press play on this, and I'll try and talk you through what we've seen. So this is an unfertilized egg, and if I hopefully it'll play. Here we go. So there's the embryo developing, and now you've seen 2 circles appear right in the middle of the egg. And those 2 little circles, they look like 2 eyes looking up at us, and that's telling us that the egg is fertilized. So one of those contains all of the male DNA, and one contains all the female DNA. So if I let it develop further, and they just disappeared.
Yeah.
And when they disappeared, what was happening there is the male DNA and the female DNA for the first time have mixed. So you could argue from a genetic point of view that this is now a genetically unique egg, unique embryo. We'll then go on a little bit further, and there we go. The embryo is now split to 2-cell stage, and now it's at 4-cell stage. So this is day 2 of development, where the embryo has 4 cells, and then it rests for a little while, and then again splits again, and now we're at 8 cells. So this is on day 3 of development. So like I was saying, some patients, certainly in my earlier career, had embryos transferred at this point, and there are a small group of patients who may have transfer at this point, but the vast majority of them go on to day 5. So if I go a little bit further, you'll now see the cells all sort of squish against each other. And I always say to patients, so this is day 4 of development, or something that we call the morula. And the embryo, it's named morula, is Latin, comes from mulberry. It looks a little bit like a berry. There's not a lot we can tell about it because it's just all sort of squished together. And then we're 5. And what we're seeing now, just in the middle of the embryo, you'll see a gap starting to appear. And that's the embryo starting to form its cavity. So now it's starting to inflate itself like a balloon, as I was saying. So if we go a little bit further, and you'll see it's inflated even more. So basically what it's doing is it's pumping fluid into its interior. And as that fluid accumulates, it starts to make it inflate. So we can already see just around the edge of the embryo here, this is the starting of the placenta. And the little lump just up here is the starting of the fetus. And if we go a little bit further, and it'll just keep getting bigger and bigger and bigger. And if I'll just try and take it just to the end, just so I can show you. Yeah, so the little lump we see up here, up at sort of 2 o'clock, 3 o'clock, that's the fetus. It looks like a little clenched fist. That's ideal. Just the rest of the embryo, although some of it's out of focus, you can probably see it looks a bit like the surface of a pineapple or a patchwork quilt.
Yeah.
So that's a beautiful embryo. That's exactly what we would want to see. That's almost a first-class embryo, which would have a very good chance of implanting. Yeah,
watching that back, I just remember seeing that kind of that rapid growth, like those cells. It became 2, then came 4, then came. It just happened so quickly. But it's one of those things that you kind of know it happens, but until you see it, it's absolutely amazing. No, thanks for sharing that. And obviously the people that are watching this can see that real visual of actually what's happening, because you're told this is what's going to happen. We do it on, we fertilize it, or we put them together, and then the fertilization happens. and then on day 5, hopefully we'll have a transfer. But you like what happens in the middle, and that was amazing. And you said it, it's a beautiful thing to watch because it is just
It
such a
is.
phenomenal thing.
It is.
So, how do you decide what to transfer, like immediately, or to freeze? Like, what makes that decision?
So a lot of clinics nowadays will have time lapse where the embryos are filmed, but not all clinics. So some clinics will, if they don't have time lapse, they will each day they will take the embryos out, put them on a microscope, and just take a 30-second look at them. So they'll sort of get a snapshot each day, just a 30-second view. For the clinics, and I think that's probably most clinics now who have time lapse, we don't have to interrupt the embryo, so we can come in each day and just watch video footage of their development. And by watching the video footage, so first, just like in the video that we just saw, I saw that embryo developed into a beautiful embryo. It had inflated, it had expanded. We could see the placenta looking like a patchwork quilt. We could see the fetus looking like a clenched fist. So I know that that's a first-class embryo. So there's a very good chance that I would transfer or freeze that embryo. But the thing is, exactly like that one. So what I would do when I have time lapse is I would watch the 4 best ones develop and see which one got to the 2-cell stage the quickest, got to the 4-cell stage the quickest, got to the 8-cell stage the quickest. So you can look at those type of parameters. So even if on day 5 of development you've got 2 or 3 embryos which are all top quality, you can look at the development over the last few days and see which embryo hit the time points the quickest, which may then have the highest chance of implantation. And to take that just one step further, as everything is nowadays, we're in the era of AI now, of artificial intelligence, and we use that as well now. So, and one of the reasons we is because I've been looking at embryos for over 30 years. I've got a very trained eye, but there are many things that my eye can't see in the development of an embryo that a computer can see. So sometimes if I've got embryos that are very similar, have a favorite, I may get AI to take a look as well. And it may see patterns that the human eye can't see. And then that grading system. So when I was talking about AAs and things like that, so an embryo that's inflated, it's fully expanded. So that goes normally from a score of 1 to 4. So the higher the number, the better. So if an embryo is a 4AA, then that's a beautiful embryo. So a 4AA, I may choose to transfer. If the patient has got 3 or 4 of them, then obviously I'm going to transfer and freeze them. And then as the quality of the embryo starts to decrease, so if one of their embryos scores a BB, I would still, but I wouldn't freeze it as my first choice embryo. So that when I thaw it out, 6 months, 2 years, 5 years from now, who knows, I get to then thaw them out in my order of preference that I froze them at, so we can still put them back in my order of preference.
Yeah, we for my daughter, she came out frozen cycle, and we'd put in a grade A, which wasn't successful, and I'm pretty sure she was a B in terms of grading wise, and we were with it. So I had a lot of anxiety about that. I remember the distinct difference in terms of the grading,
Yep.
but they can still be successful. They can be. I think that's one of the worries about grading.
Yeah.
People
And in
assume that it
fact,
won't be.
yeah, you can almost flip it on its head, because when I get patients who have got perfect embryos, they're not all going to get pregnant from those perfect embryos. And that's because sometimes an embryo can look perfect, but genetically it's not, and it doesn't. And likewise, you can have an embryo that doesn't look as perfect, which means it's not your first choice embryo. So maybe you do freeze it, but actually the DNA inside it is completely normal. And the number of cases I've seen over my career of patients who maybe they've had 5 embryos frozen, and they've ended up transferring them all, and it isn't until the last one, which by definition is our poorest choice embryo, that they get successful from.
Yeah.
So though there's a correlation between how the embryo looks and its chance of implanting, Mother Nature makes a point of very often letting us know that we can be wrong. It doesn't matter what we see. An embryo of lower grade. I've seen many babies born from lower grade embryos.
Yeah, I think that is the a key takeaway there, isn't it? Nature knows what it's doing. Yeah, even if the process to get there sometimes doesn't feel as natural as it should, especially when you're talking about IVF and ICSI. When that embryo is put back in, nature takes over and it does what it wants to do. There's not much more you can do after that.
Yeah.
I'm conscious of time and things because we've had a great discussion and I've really enjoyed it. There is one more thing I just want to say in terms of obviously going through fertilization. What kind of communication can patients expect, and what should they get, or do you encourage it, or there's a lot of questions about the communication?
I mean, I think personally, I think the more contact patients have with the embryologist, the better. And I tend to think patients feel the same way too.
Mm-hmm.
So for instance, what we will do is I will call on the day of egg collection. So if a patient's having ICSI, when we do ICSI, we have to, when eggs come out, an egg has a cloud-like group of cells around it. And for ICSI patients, we have to remove that cloud-like group of cells. And so at that point, we get to find out how many of the eggs are mature. That's on the day of egg collection. With the IVF patients, we don't find that out until the next day. But with ICSI patients, we call them on the day, just after we've done the ICSI, to let them know how many eggs were mature. The following day is, so the day the eggs come out is day 0. So I call them the ICSI patients on day 0. I call ICSI patients and IVF patients on day 1. So that's when fertilisation happens. So we call them to let them know how many have fertilised. We can then call patients with an update on day 3 of development when they're at the 8-cell stage. And that's up to the patient, because sometimes I think patients can get anxious by having to wait for calls from us. So occasionally you get patients who actually don't want that much contact. We will always, of course, see them on the day of embryo transfer. So day 5, we will go and talk to them. I will talk them through the whole pineapples, oranges, clenched fists, all the things that I've just discussed with you, to tell them how we grade the embryo, which ones we're putting back and why, and of the remaining ones, whether they're of freezable quality. Now, any embryos that are on day 5 that are not of freezable quality, we then grow until day 6, so the following day. So then I call patients again the day after they've had embryo transfer, and I will say to them, it may be that, we put 1 back yesterday, we froze 2 yesterday, I've checked the remaining embryos, 1 of them has developed well overnight, so we've frozen another 1 today. So sometimes we can freeze on day 5 and day 6. And then, of course, there's a small group of patients who tend to be the patients who over-respond to medication, where it's not wise for us to do a fresh transfer, where we're only going to do a frozen transfer. So that means that those patients wouldn't be coming in for day 5 to have a fresh transfer. So if we would telephone them on day 5 and day 6 just to keep them an update of when we're freezing and what we're freezing.
Yeah, it's one of those things that definitely comes down to, as a patient, it's your personal preference as well, in terms of if you don't want to be contacted, it's absolutely fine to say that we're just going to step away for a few days, because it is a really anxious time, like an incredibly anxious, because I talk about milestones in fertility treatment, and it's one of the big milestones. Like, you've managed to get something, you've put it together, what's going to happen to it? So yeah, anyone listening to this, do what's right for you. And
sometimes just ask questions that. Sometimes I think patients think they don't ask a question because they think it's a stupid question or something like that. And whatever question it is they want to ask, I guarantee will have been asked in different ways 1,000 times. And sometimes I even have patients, and I quite like this, when patients will say to me, they'll say to me, what should I be asking you? Or they'll say, what should I be worried about?
Yeah.
And I think they're both really sort of open-ended questions, where if a patient said that to me, I would then just give them bits of information to say, look, don't worry about this, don't worry about this. This is in my hands. This is what I can tell you. And it just gives them that little bit of knowledge so they don't have to be too anxious.
Yeah, that goes back to what I was saying with the fertilization as well. Like, there was so much worry about it. And to have someone say to me, like you've just said, but we've got this, this is what you need to worry about. Right. And
Yeah.
the honest truth is, once it's done, it's the anxiety of wanting it to be successful. There's not much
Yes.
else you can do, is there?
Yeah.
I do have one other question, actually. In terms of the embryos that don't make it, what
Yeah.
happens to them? Because I wondered that, because you can't just pour them down the sink. I wouldn't have thought. Like, is there a way of
No, no,
getting
no.
rid
So
of them? And
no. So they're by definition for an embryo that doesn't make it. So for instance, when I'm looking at those embryos on day 5, when they're at the blastocyst stage, and when they should have 150 cells, and
Mm,
you should be able to the fetus and the placenta, you're always going to get embryos that don't make it to that point. And the reason that the embryos don't make it to that point is almost entirely just due to genetic abnormality. And that's just the way that humans are. Humans are not the most fertile of mammals. So a of human embryos, even from the most fertile of patients, just won't get to day 5 because some embryos will be genetically abnormal. They lack the potential to implant and they will stop growing. So the ones that stop growing, they're not of transferable quality, they're not of freezable quality. We certainly believe that they won't implant, so they're just discarded. And when I say they're discarded, we will have transferred the best embryos, frozen the remaining ones, and then the embryos that are remaining will be discarded in their dish. They go into a biohazard waste system, just in the same way that any human tissue would, that's going to be discarded,
yeah.
disposed of, and then they're discarded that way, just clinically.
Yeah, it was definitely something that I thought of. I think it was just a ignorant man at one point thinking, well, you can't just pour it down the sink. What happens to it?
No,
Because it is,
no,
it is part of the human, isn't it? It is the beginning of it. So, no, thanks for clarifying
yeah,
that. So we've got a few questions. We've got some pre-submitted ones. I've just been looking at them and we've covered quite a few, but we've got some that have come in
yep,
as well. So this was
yep.
going right back to initial conversation about smoking, and it says, is there any data or research on whether vaping affects sperm quality and embryo quality?
It's a great question. I will tell you that I wouldn't. I'm unaware of data, and I wouldn't think there's data out there on it yet. However, I would expect the data to be very similar to what we've seen with smoking, but I guess slightly with the volume turned down a little bit, because my understanding of vaping is that certainly a lot of vaping still contains nicotine products, and we know that nicotine's the problem. I know
Mm,
that nicotine has an effect on hormone levels, on sperm production. It can lower counts, it can lower motility, it can change embryo development. So if somebody's vaping and the vape has nicotine in it, which my default assumption is it probably will, then there has to be some effect. I would think it's probably slightly more subtle than with a cigarette, because I would imagine that the nicotine content of a vape is lower. That's to my knowledge. But certainly, yes, if somebody's vaping and there's nicotine in it, I would assume that there will be some effect on sperm production and on embryo quality if you have treatment.
yeah, it's vaping is definitely, because it's so new, there's no
Yes.
real research on it yet, is there? It's probably going to something that we're going to see 20 years down the line. Um,
Yep.
just not just with fertility, but broadly in terms of the effects it
Yes.
actually has on your health. End of the
Yes.
day, it's chemicals, man-made chemicals you're breathing in. So
Yeah.
yeah,
Yep.
and as you've just said, nicotine's there, so it is definitely a not good cocktail for fertility. So there's another one that says, in the case of hedging your bets, as you mentioned, in terms of 5 IVF and 5
Yep.
ICSI, is this
Yep.
something that might be offered by a clinic, or can a patient suggest or push for this?
Um, I think some clinics offer it, some clinics don't routinely offer it, but certainly a patient can push for it. I mean, there's really no reason why. Certainly, the lab are flexible enough to be able to do that for you. So if you go in and you early on in treatment say, look, we're very concerned about the risk of this cycle failing because we don't get any fertilization, and as a sort of an insurance backup for ourselves, we'd feel much more comfortable if there was some ICSI done. And of course, the vast majority of the patients that do some IVF and some ICSI, will get perfectly normal fertilization in both. So
Yeah.
for most patients, they'll do the half IVF, half ICSI, and IVF will fertilize both. And then with the benefits of hindsight, you'll go, okay, didn't really need to do the ICSI, but we were, taking being sure, being safe. But I've seen the other group of patients. I've seen the patients who do half IVF and half ICSI where the IVF doesn't work and
Yeah.
the ICSI has saved their cycle. And the
Yeah.
ICSI means they have embryos. It means we're doing embryo transfer. It means they can get pregnant without having to go through the whole emotional roller coaster and often financial roller coaster of doing, well, it would be a ICSI cycle, a repeat cycle.
Yeah.
So yeah, I definitely recommend people ask for it. And there's no reason a clinic can't do it for you.
Amazing. I mean, I think that's one of the big things, especially if you're, I don't want to term them new to it, but in terms of you haven't done a few cycles yet, like you don't know what you can and can't ask for.
Yeah,
And I
yeah,
always think, well, now I know what I know. Ask. The worst thing that's going to be said is no. You know,
yes,
you don't know what you're going to
yeah,
get until you ask. That's in life in general. So definitely ask the
yeah,
question.
yeah.
I've got one more. We're going to take one from the pre-submitted questions. I feel like this might have several answers, but maybe we can think about maybe the common reasons, because I think it's something that people definitely think about. So why do some embryos stop developing even if fertilization was successful?
So that comes back to my point a few moments ago, in that a certain proportion of human embryos are genetically abnormal.
Mm.
Um, now that's, you will see it more as a woman is older. So, for instance, if I had a 30-year-old patient who had 10 embryos, then statistically, that 30-year-old's 10 embryos, 7 or 8 of those embryos are probably going to be genetically normal, and 2 or 3 of them are probably going to be genetically abnormal. And the ones that are genetically abnormal are less likely to make it to day 5. They're less likely to therefore be freezable or transferable. So with a patient like that, you tend to likelihood transfer an embryo that has the potential to implant and freeze embryos that have the potential to implant. If I had a 40-year-old who has 10 embryos, those numbers are flipped on their head. So now I've got maybe 7 embryos that are genetically abnormal and three embryos that are normal. So it's much more likely with an older patient that you could end up transferring embryos that lack the potential to implant. And that's one of the reasons that in the older patients, so a patient who's over 40, we can transfer up to 3 embryos. And that's to cater for the fact that 1 or 2 of those embryos statistically will lack the potential to implant. So the biggest reason that embryos don't make it to day 5 is because of genetic abnormality. And that can be linked to things like female age, but it is just generally linked to human fertility, because in that 30-year-old patient, we still have 20 or 30% of embryos that don't make it to day 5, and that's because they're genetically abnormal. So it's just a human fertility phenomena.
Yeah, it comes back to what we mentioned before, doesn't it? It's nature doing
Yeah,
its course and knowing what's right and what's wrong. And but thank you very much for that answer, because it's definitely something that I've said it several times. I thought of people listening to this would think of like what stopped it from happening, and just that little bit of information of it wasn't quite right, so the nature did its course.
yes, absolutely.
Thank you so much for this evening. It's been really
That's a pleasure.
informative. I've really enjoyed myself, learnt a lot. I hope you've enjoyed it, and
Yeah,
I'm sure that the guys that are listening back in the future will do as well.
it's
So we'll leave it there tonight. Thank you so much, and
a
I'll speak
pleasure.
to you again soon.
Have a good evening. Take care.
Take care. Bye.
Bye. Bye.